Hi, this is Dr. Sarfaraz Braig, and I bring greetings from Digestive Surgery Clinic. And today we will be talking about an overview of obesity. Now, let's play this game before we take off from here. You can see that the choices I have given on this quiz, the odd one out quiz, is tuberculosis, malaria, cancer, undernutrition, and obesity. Take 5 seconds to have an answer. So the right answer is undernutrition because tuberculosis, malaria, cancer, and obesity are all diseases. And I want to play this game, and you will not believe every time I go to a public audience, we find that many of our many folks actually press on obesity as the odd one out. And the reason is people do not visualize or imagine obesity as a disease, but they do that for the undernutrition, which is not correct. Now, the new term for obesity is now adiposity based chronic disease, implying A, that it is something that is there for a long, long time, chronic. And number two, it's a disease. It's not enough to understand this as somebody who's just gained a few pounds more. No, it's not. It's basically a disease and carries with it a lot of associated diseases. Now, a very uh, popular definition of obesity is a BMI more than 30. And in Asians, because we tend to have more diabetes as well as metabolic diseases such as liver disease, infertility, with lower BMI, the BMI has been dropped to 27. The diseases which are associated with obesity, and some of this might be very easy for you to comprehend, are diabetes, cholesterol issues, risks of some cancers like breast, colon, and endometriosis, mood disorders like depression, heart disease like heart attacks, reproductive disorders like infertility, polycystic ovarian diseases, liver disease such as fatty liver disease, NASH and cirrhosis, and hypertension. So these are some of the common diseases associated with obesity. Now, what causes obesity? You will be again surprised to know that this is the commonest model that we talk about when we talk about the cause of obesity, which means that the more I eat and the less active I am, the net result of these two processes is going to determine how my body weight is going to be. Although this is a rough approximation and roughly correct to begin with, this is not the absolute truth. Because if you look around you, don't you see that people who eat the same thing and eat the same food and have the same sort of a lifestyle still have a vast difference in body weight? Don't you see in your own life that you may be eating differently on different days, but on the body weight scale, you might find that the scale has not even moved by a gram? The reason is that the body weight is controlled by our hypothalamus or the brain. And whatever the brain determines, it's what the body weight is going to be. This explains why some people may have higher body weight despite having less food, and some of them will have lower body weight despite having a lot of food. Now, what tells the brain what body weight to keep? So it is basically the gut. The gut has hormones, nerve connections with the brain, and there are gut bacteria which give signals to the brain. And all of this, uh, by giving signals to the brain, determine what the body weight is going to be. You might go one step further and say, then what actually emits signals? What stimulates the gut to produce these signals to the brain? And the answer may be genes, maybe genes, just genetics. Some people have good genes and they might be producing the right signals and remaining healthier with less body weight because they can metabolize the extra calories. And some folks can't do that because they have bad genes. This important concept is called the set point hypothesis, which basically means that the brain determines what the body weight is going to be. Behind that is the gut, behind that may be the gene. So that is the hypothesis nowadays. This explains why we should not blame individuals for their body weight. Rather, we should try and understand the complex multifactorial polygenic mechanism of our genes. So if we look at this paper, roughly, if you ask me, what is the genetic contribution to obesity and what is the environmental contribution, so to say, it's about 70% and 30% based on this paper. So many times I keep on hearing this in different forums that if you eat better and move more, then you're going to lose weight. Well, yes, but this is not entirely correct. As I mentioned, there are genes, biological processes involved, and these are beyond our control. And these things cannot be controlled by just moving more and eating less. Rather, we now should say that the treatment for obesity should be individualized. How do we manage obesity? Well, obviously, the first thing is have a great diet, have a natural, unprocessed food with a lot of fruits, dairy products, high proteins like eggs, fish, and chicken, and have a lot of yogurt. So these are the composition of a good diet. In terms of lifestyle, it's important to do some activity on a daily basis. And finally, nowadays we realize a good mental health is an absolute necessity to a good body weight. Let's talk about the success rate. Well, in somebody with mild to moderate obesity, which means BMI less than 40, it's possible that all these things may produce decent results. However, if you look at this large database coming from a big nation, you find that in lakhs of patients being followed up for approximately 9 to 10 years, one finds that the success rate of lifestyle and diet on producing success for severe obesity, which means BMI more than 40, is just 1 in 1,000. And that is the stumbling block. So, what do you do for these patients who have a BMI more than 40? That's the severe obesity. Well, the answer may be in bariatric surgery. And as I mentioned earlier, that the cause of obesity is not only as simple as eating more and working out less. It's not just a bang balance, rather a complex mechanism where the control of brain is there because of the signals coming from the gut. Many of these are controlled by genes. So the bariatric surgery now works in directly on the gut signals. We can't change the genes, but what it does alter the gut signals. It also reduces the capacity of eating food, and by these two mechanisms, it gives great results. Now, therefore, with that statement, I will come to this slide where the indications of bariatric surgery is therefore somebody with a BMI more than 40 or somebody with a BMI more than 35 with one or more diseases such as diabetes, hypertension, cholesterol. Nowadays, even a drop of BMI to 30 has been advocated for patients with diabetes. Obviously, we try to avoid this surgery in younger patients who have not attained bone maturity, elderly patients who may be having high risk and have a lower longevity left, the patients with psychiatric disorders untreated, like depression, bipolar disorders, may also be a contraindication. And patients with addictions to smoking, alcohol, and drugs are also not the right candidates. In terms of procedure, I just want you to pay attention to these four common procedures. One is the gastric band. Nowadays, not so popular, but it was a simple thing to put in a band around the proximal part of the stomach and to make patients feel full with eating less. The gut signals were also altered, as I mentioned earlier. But the sleeve gastrectomy, the second procedure at the top, what you can see where you 80% of the stomach on the left side is excised, leaving a banana-like stomach. This is a very good surgery where 30% of the weight can be lost. Lower down, you find two gastric bypasses where not only the stomach has been reduced, the intestines have also been bypassed, especially the duodenum and the jejunum, whereby we are reducing gut signals further and leading to changes which cause improvement in metabolic issues such as diabetes, etc. Recently, we now have seen a flurry of newer procedures, bariatric procedures, which can be done endoscopically. One is a gastric balloon, the other one is a sleeve gastroplasty. In the balloon, we take a endoscope and put in a balloon which can stay for about 6 months to a year, and we can reduce about 5 to 10% of body weight. Endoscopic sleeve gastroplasty is a newest kid in the block. We can suture the stomach from inside by permanent sutures, and that can produce a weight loss of about 20%, up to 20%. Well, the outcomes of the surgery are good. If you look at the weight loss, there is absolutely no other method to produce a 30% weight loss. These are dramatic weight loss seen in no other treatment so far. And if you look at our literature, and this is our own published data from many centers that collaborated with us, and over 5 years, you find that the weight loss is pretty good and it is sustained at 5 years. From the Taiwanese series, even at 15 years, you can see that the mean body weight is still quite low, although some patients do regain weight, but that's a separate talk altogether. Well, if somebody did a bariatric surgery and another obese patient did not, how would it influence on mortality and cardiovascular diseases? So this study coming from Sweden, where 2,000 approximately patients, obese patients who underwent surgery versus those who did not, they found that the patients who underwent surgery had a lesser mortality rate, lesser death rate, less chances of heart attacks, and less incidence of diabetes as well. If we look at obese diabetics, this is a very famous STAMPEDE trial, where it's a randomized control trial, which means this is the highest evidence possible uh, in such situations. So obese diabetes was subjected to bariatric surgery versus plus medical therapy versus just put on medical therapy. And what was seen was that the remission was 5% in medical therapy, whereas it was close to 30% in bariatric surgery. So a hands down winner, it was the bariatric surgery in this group. Many patients nowadays have fatty liver disease, NASH, and even cirrhosis. And in this group, if we were to do surgery, especially in cases of NASH, this paper, which is called the Splendor study, comes from the US, where they looked at 650 patients who underwent bariatric surgery for NASH, which is obesity related liver disease, and versus 500 patients who did not undergo the surgery. It was found that 40 out of those 500 had adverse liver events such as liver failure, need for liver transplant, etc., whereas only 5 out of those 650 required. So again, those who undergo surgery, bariatric surgery, do have a tremendous benefit. What about patients who are infertile? And this is a big, big topic. And I did not want to go into the um, depth of the matter, rather keep it very superficial, at least for now. And we can see this is a systematic review, which means they collect all the good data in the literature, published literature. And what they found was, I'm just going to quote it from this paper, that bariatric surgery effectively improves fertility outcomes for both men and women by hormonal level changes in the favor of the patient and improvement in the sexual function index score. And by doing that, many patients do conceive without any artificial reproduction. Most patients were satisfied with their surgery. So that is an important thing, because no matter what we say about the surgery, it's ultimately the patient who has to report how they feel after the surgery. And it's comfortable to see that many patients, large majority, say they are very happy about the surgery. Looking at the adverse outcome, the short-term complications are the leak, bleed, and injuries, and that can happen in 1 to 3% of patients. Depends on which center we do, the complication rate can be lowered down even further. In the long term, we find that nutritional deficiencies is seen in about 5 to 20% of patients, especially in those who are not complying with the bariatric supplements. Weight regain is again seen in 5 to 25% of patients, depending on what procedure was done and how compliant the patient is towards a good lifestyle. Reflux again is seen in about 2 to 5% of patients, and this is a relatively common problem, but manageable by medicines and lifestyle changes. And the other complications are too rare to be discussed here. The take home message from this, I must say, is that we need to change the mindset of patients, society, and even doctors regarding the obesity management. This is not a problem where there's a lack of willpower of the patient. More often than not, this may be a biological problem, a genetic problem, a multifactorial problem, and therefore the treatment has to be multidisciplinary. Everybody has to come in, the nutritionist, the psychologist, the surgeon, the plastic surgeon, the metabolic physician, the endocrinologist, all need to come in together to deliver the most appropriate and optimal treatment for obesity. Uh, there is definitely a role of bariatric surgery in a select group of patients, especially those who have metabolic syndrome like diabetes, cholesterol issues, infertility, NASH. So it's important to realize it is not only about treatment of obesity, but rather treatment of obesity associated diseases. And I must say that the awareness of this surgery is rather low in our country, and we need to improve on them. And with that, I must thank you for your attention. If there's any question that you have, you can put it in the comment box below, or you can look at the mail address that we have posted down below. You could mail us with your specific question, and we'll be very happy to answer it. Thank you very much.